Okay, well, my talk is not going to be a rocket scientist. I'm only going to explain some clinical experience we have with NAVA. So, here, as I'm not as famous as the other speakers, I'll introduce myself a little bit. I am a senior researcher at the Nijmegen Respiratory Muscle Lab, and we are looking at the effects of acute and chronic diseases on respiratory muscle function. We are doing studies, biochemical studies, histological studies. We're doing studies in patients, in vivo muscle function. But more than that, I'm a clinician, and I think it's very important as a clinician to think about the problems patients have and how we translate that into research. And a little bit of spare time I have, I spent with my two boys at the Feyenoord soccer stadium. So in the next 20 minutes, I will talk about how did we implement NAVA in clinical care. It's now part of our routine work. How do we do that? Which patients do we select? I know it's open for discussion, but what kind of patients do we select and what are the problems and what are the limitations? So this is our hospital. It's, at least for Dutch standards, a large university hospital, 1,000 beds, 34-bed ICU. In 4 different units. It's a neuro ICU, cardiothoracic ICU, and 2 mixed medical and surgical ICUs. And we started out with NAVA something like 2009. I think well before all the studies were available that are available at this time. So we started out when there was very little experience. And I think at that time, we had a lot of help from the company. I think when you start a new ventilatory mode, you have to learn it from people who are experienced. Don't feel too good to ask them. So we had training from the company. First, we trained the doctors. We trained nurses in separate occasions. And we started with NAVA in 1 of our 4 units. That's what we do when we have new developments. Start in 1 unit, see if it works in clinical practice. Then we had, for every unit, 2 to 3 expert nurses. And I think that was part of the success, because it made nurses to ask their colleagues if they had questions. They don't have to ask a doctor. I mean, they might be hesitating to ask stupid questions to doctors. So it was a good idea, I think, to have a couple of expert nurses who did really, really well. And at least in the first year, because I think that's the time it takes to change your clinical practice. In the first year, we had a really frequent backup from the company. If we had questions, we went back to them. We sent them screen dumps, asked them, what's happening here? I think that was important. Even though we are very focused on mechanical ventilation, even though we are very focused and interested in respiratory physiology. I mean, there are a lot of things happening. So the backup, at least in the beginning, is very important. Because we're a university hospital, we always think that our protocols is better than other protocols. So we rewrote the protocol, which included, say, which patients should be included, which patients should be excluded, typical troubleshooting, these kind of things. And I think it was important to the success as well, because the protocol was approved by the nursing staff and the medical staff. So anybody could have comments in the first phase, but not after the protocol was approved. I mean, you could say, you agreed with the protocol, so this is the way we're going to do it. No discussion about it, at least not in clinical care. Let me see. Okay, then when you start out with NAVA, I think it's really important to start with the easy cases. Don't start with this fellow. A patient in prone position, inhaled nitric oxide, 90% of oxygen. He's not very forgiving. We just heard. We can start with NAVA and ARDS, but don't start when you are a new user. I mean, we did NAVA in this patient. It was really interesting. I mean, his oxygenation improved dramatically. It's just an example, but don't start with these patients. We started out with the easy patients, those what we think had obvious patient ventilator asynchrony, who had COPD. I mean, these are the forgiving ones. And then you can see it. Well, you've seen these screen dumps many times. There is asynchrony pressure support, and just switching to NAVA. You see 5 of PEEP, 8 of pressure support. Switch them to NAVA and they're doing fine. These are the good patients to try. You can change NAVA level, you can change PEEP, see what happens with the signals. Even more important, I guess, is having meetings at the bedside. When we have patients on NAVA, we would go with a group of doctors and nurses to all those patients. Look at the screen dumps. Look what happened the last 24 hours. Look what happens when you change ventilatory settings. I mean, there's so much to learn. You can learn much more at the bedside than from 10 keynote presentations, I'm really sure. These kind of things, for example, we see it happening. This is a patient, I think it's a patient with ARDS. And it was here, very high EDI levels all the time. It doesn't go back to baseline. It's good to have the discussions at the bedside. What's happening? What's happening when I change the NAVA level? What's happening when I change PEEP? You don't find the answers in the literature. Make your own experience. It's so exciting. And in particular, when you have the expert nurses accompanying you. I mean, this is great. This is also, you have seen these kind of slides. It's such a nice example. We had doctors in our ICU saying, well, asynchrony, it happens in the literature, but it doesn't happen in our hospital. Remember, this is well before the paper by Paulo. I mean, these kind of things, it's so obvious. It happens. It's really nice. The other thing is, sometimes we have problems at 3 at night. So nurses don't know, doctors don't know what to do. I just tell them, make a screen dump and switch back to pressure support. I don't care. So we can discuss it the next day. See what's happening. I mean, that's, I think, a good thing to do. It's good because it increases your awareness for mechanical ventilation. What are we doing? So this is what I have discussed. Went everything smooth? Well, I don't think so. We had a couple of problems. I'll just discuss some of them. The chaotic breathing. We have discussed it a little bit before already. People were complaining that when the patient was in NAVA, respiratory rate goes up. There's so much variation in tidal volume. You just heard it. It's physiological. But we were not very used to it. We were not used to having intermittently high tidal volumes, having periods of high respiratory rates. I would say, don't care too much. This is what the patient wants at this time, so we're going to accept it. Of course not when he looks very agitated, when the patient looks uncomfortable. But we're not going to change the settings just because there's variation in tidal volume. This is physiology. This is why we bought NAVA. We had some discussion about insertion of nasogastric tubes. In our hospital, normally nurses would do it. But when we bought the EDI catheters, I thought it would be the best to have doctors doing it because it's gold. Well, it's ridiculous. I mean, nurses can do that much better than doctors can do it. They do it faster. And more importantly, if I say I'm going to put in the catheter, that's okay, but I have to finish my rounds first. I have to do intubation. I have to put in the central catheter. It's going to happen at the end of the day. We just had the nurses doing it, and it's going fine. Discuss the catheter a little bit later. And the other thing I did wrong, I guess in the beginning with the training, I made it too complicated. You know, I love respiratory physiology. I love the control of breathing, love the discussions we have here. And you do, people in the room. But most people working in the hospital, they don't care. I mean, and particularly 3 o'clock at night, they don't care about these discussions. They want to have the patient ventilated well, and they want to have easy troubleshooting. So I changed my courses, made it easy, and only for the expert nurses, only for the expert doctors, we had discussions about the physiology. We had the complicated, the very difficult screen dumps for discussion. But not for everybody. Just keep it simple. If you want to change clinical practice, keep it simple. Well, that's the same thing with how do we set the NAVA level. You have seen these pictures. I mean, it's nice papers in the literature that you can do the kind of titration curves. And I started out with it. And it works, I know. It is feasible, you can do it. This is not the most representative picture, but it's one. And you can see it works, it's feasible, but it takes a long time. You think people are going to do that twice a day? Don't think so. It's not going to happen. The other problem is, some of the patients have these kind of figures. I mean, you increase NAVA level, but there's no there's no change in, there's not a clear plateau. I mean, what do you expect a nurse or a doctor who's not really interested in mechanical ventilation wants to do? That's not going to work, really, it's not. So what I decided to do is just use the overlay window. Just give the same level of support as you would give with pressure support. I mean, there's no evidence in the literature that this is not the right way to go. There's some physiological evidence, but there's no clinical evidence to show you that doing a titration curve is so much better. So that's why we went back to just looking for the same level of support you would do in pressure support. So how do we now with the NAVA? I think the most important thing is when it went to a success, is that we had to keep it simple. And it is simple. So in patients with non-ARDS, we first target the same level of support as we would do in pressure support. Patients who are awake titrate on comfort. I think that's very reasonable to do so. And in ARDS patients, we titrate at about 6 ml per kilogram. And usually it works, not always, but usually it does. How do we wean? I mean, that's a complicated question as well. I think as a scientist, as a physiologist, you could use a lot of parameters. I mean, it has been discussed a little bit today. You could look at neuroventilatory efficiency, your tidal volume divided by EDI. You could look at changes in EDI while a patient is having a spontaneous breathing trial. Very interesting from a physiological standpoint. I will look at it, but you can't train your nurses. You can't train your colleagues in doing that, at least while there's not the evidence. So why not do it like we would do it with pressure support? Just a gradual reduction in support and do spontaneous breathing trials, T-tube trials, twice a day. I mean, that's the most easy thing and the most easy way to go. So again, also with weaning, just keep it simple. The other thing is that we were looking for, and that's, I guess, a little bit different in Northern America, but how would be the responsibilities between the nurse and doctor? How we do it at this time is nurses would usually put in the catheter, they would do the right positioning of the catheter, they would select the initial level of support, at least in the patients who do not have a severe ARDS, and the doctors would do more the fine-tuning. I mean, that works fine. Nothing special about it. Does NAVA always work? No. This is just an example. This is a patient from the ER who had a pneumonia, probably atelectasis right here. We put in a catheter, and it looks like this. I mean, very high activity, and the EDI doesn't get back to baseline. And if you look here, there was adequate positioning of the catheter, but still very high. I call it a kind of tonic activity of the diaphragm. Whatever we did, increase PEEP, decrease PEEP, increase NAVA level, decrease NAVA level, we just were not able to have him on the NAVA in a comfortable way. Sorry. So we just put him on pressure support. Don't worry. I mean, I guess it's a kind of second best, and we'll try it tomorrow. And very often, it works tomorrow. I think, and that's here, it summarizes the most patients I would recognize as a clinical perspective who are failures on NAVA when there is an acute change in the position of one of the two diaphragms. And you see that with atelectasis. It might be pneumothorax. It might be a very recent pneumonectomy. There's a change in the position of the diaphragm, and the diaphragm goes in a kind of tonic activity. So don't worry. We do pressure support today, and usually tomorrow they do fine. And also patients with an exceptionally high respiratory drive. The patient who has a pH of 7.1, a PCO2 of 10 of kilopascal, 70 millimeters of mercury, with such a high drive, it's really difficult to have them on NAVA. You could try with some sedatives, but usually it's really difficult. So what's the typical problems we had? Well, this has been discussed. No signal. They call me, we have adequate cardiac signal, but there is no activity of the diaphragm while the patient is doing fine on pressure support. It's always this. It's always over assist. I just can tell them by phone, just reduce the level of pressure support right here from 12 to 6 and you'll be fine. And it's true. Other things, it's more practical. With the small catheters, we have obstruction of the lumen, so you have to flush it a couple of times a day, in particular if you use it for feeding. Too many alarms, we'll discuss that later on a little bit. And one of the things, at least initially, is unwillingness of colleagues to adapt to the protocols. I mean, and that's what I recognize right now. Changing ventilation practice has a major impact. Sometimes it's difficult to have people aboard. But one of the things that we did is communicate your success. We had the communication department of our hospitals, and we told them, we have something really new right now. While patients are mechanically ventilated, they are in charge. They breathe by themselves. They have their own breathing pattern. They picked it up in local newspapers. They even picked it up on the national news site. I think, and then people think, well, there's something going on here, and you get your colleagues aboard. So how do we do it? At this time, we select the patients in which we expect they will be in the ICU for more than 3 days. In particular, the patients with obstructive lung disease, difficult weaning. We use it as a monitoring tool in these patients as well. Patients with severe ARDS, we put in a catheter right away, just for the monitoring, see what's going to happen. So this is the, at this time, so we have 4 to 6 patients on NAVA, so every day. And when I was preparing this talk, I was thinking, why don't we have all the patients on NAVA? Well, sometimes it's because the patient already has a nasogastric feeding tube, and we're unwilling to change it. And still, it's sometimes an issue that a doctor or a nurse might feel unsure to go to NAVA. So it's important to keep training, to have educational sessions all the time. So we have recently rewritten our protocol. It's now available in English for anybody who wants it. And I want to conclude with this slide. So what have we learned from the implementation? The major thing, I already said it, the major thing I've learned is that changing ventilation practice has a major impact. It's really not easy. For the Dutch situation, it was very important to give nurses a high level of responsibility. It's very important that you start with the easy patients. If you start with 5 patients with ARDS and they all fail, everybody will say, well, this is not going to work in our ICU. So start with the easy patients, I guess. Communicate your success. And I think what was really important when we a little bit stopped calling it NAVA and just said, this is new pressure support. It's pressure support with a couple of advancements. It's the synchrony, it's the proportionality, and you can use the monitoring. Okay, this is the slogan of our soccer group, and it says in Latin, facta non verba, and I think that accounts for changing your ventilation practice as well.
Thanks very much, Leo. Any questions? I had a question. I was curious. What do your nurses think about NAVA now?
It's part of the routine care, so they're very used to it. I think they just start out with it. I mean, when we have a new patient, they might put in, they usually ask, but they might put in a catheter and start out. So,
any questions from the audience? Yeah.
Manuel Fontes, Duke University. I joined the discussions by everyone. My question is whether you or anyone else in the audience has had experience with a lung transplant population. We're doing a huge number this past year, I think right around 150. And increasingly, we're doing singles and then bringing them back later and doing the other side. And as you well know, they present quite a challenge, particularly when things don't go well.
So anybody in the audience have wait to look at the microphone.
Yeah, we've done a couple of patients. We had 8 patients post cardiothoracic surgery, which 2 were lung transplants. They did all right with the NAVA. I can't remember off the top of my head how many days of NAVA ventilation we used them for. I've got a feeling at least one of the patients was one of those patients we had on NAVA for at least 6 to 8 days, and it worked reasonably well in that situation.
Do you think there was any particular advantage to using NAVA in that patient group?
They were just patients that had failed the spontaneous breathing trial. We eventually, as I remember, got them to pass in the end, but they may have done that, regardless.